You're welcome to my channel. Thanks for visiting. Today, it is all about escitalopram. It's a type of medication. Let's go. It is an antidepressant, specifically selective serotonin reuptake inhibitor. If you want to know more about the list of different medications that are tagged as antidepressants, you can click on this very link. That will take you there. It can come under different brand names depending on the brand that is available in your jurisdiction. Now, let's quickly go over the possible conditions under which escitalopram could be helpful. In eating disorders like bulimia or binge, in menopause when we want to deal with the vasomotor symptoms, in major depressive disorder, in obsessive compulsive disorder, in panic disorder, in premenstrual dysphoric disorder, in post-traumatic stress disorder, or body dysmorphic disorder, even in premature ejaculation. Also helpful in pediatric age group, but we have to be careful when it comes to pediatric age group. I will address that in a bit. In children, we can use it in generalized anxiety disorders affecting children greater than 12 years and above. In social anxiety disorders, obsessive compulsive disorders, and major depressive disorders affecting pediatric age group. Forms. We can get escitalopram in form of solution meant for oral use. In that case, we are going to see escitalopram itself, that is the generic form, as 5 mg per 5 ml. Can be in form of tablet that could disintegrate orally. In that case, we find this. Or tablet that cannot disintegrate orally, but when it is swallowed, then will be absorbed into the system. Then we can find the strength. The full effect of this medication is not going to manifest immediately you start it. Let's have that at the back of our mind. It's likely going to take up to 4 weeks before you can start noticing full effect of escitalopram as per your symptoms. So, cooperate with your physician, pharmacist, psychiatrist, family doctor, or as the case might be. How do we give this? The best advice is that we start very low as 5 mg or 2.5 mg as the first dose. Then we can increase gradually every week, depending on the outcome. If we are getting enough outcome, we don't need to increase. We maintain at that level. But the maximum we can reach in a day is given once daily. The maximum we can reach is 20 mg once daily. Please contact your pharmacist or psychiatrist if there's any confusion. Now, when we are trying to switch to another antidepressant or switch from another antidepressant, let me explain further. This is about escitalopram right now. Okay, that is an antidepressant, selective serotonin reuptake inhibitor. But if we want to stop escitalopram and we want to start maybe venlafaxine, then we have to give enough time. Vice versa, we have vaccine before we want to start escitalopram, we have to give enough time, as long as 2 up to 4 weeks. So we will do two things simultaneously. While we are gradually reducing the dose of the first medication, in this case, vaccine that the patient A is on, as if we're going down the ladder, we will gradually start slow and increasing slowly the dose of the newer medication, this time around escitalopram, in the same patient A, and we'll continue as if we are going up the ladder at the same rate that we are going down the ladder with the first medication. I think I have summarized it. So the first medication should be reduced gradually as if you are going down the ladder, while the newer medication should be increased gradually as if you are going up the ladder. Now, to discontinue, to stop this medication completely, you know, that is different from switching to another one, right? Back and forth. This must be done gradually, like what I've just said, you know, as per the switching over to another one, but it is even going to be more serious this time. We are to taper off very slowly over months. As you know, the other one I said 2 to 4 weeks, right? This time is going to take months, as long as 6 months or even greater, depending on some factors like, is this patient relapsing back? No, you've gone through what we can use it for, right? Depression, anxiety, panic, post-traumatic stress disorder, and everything like that. Is the condition getting worse now when we are reducing the dose gradually? If that is the case, then we will pause and stop discontinuation entirely, or we switch over to another one, like I've said earlier. Then we'll watch the side effects, or are we dealing with withdrawal effects of these escitalopram? We'll consider that. And the overall health status, overall psychiatric condition, or even in menopausal cases where vasomotor symptoms is what we are using it for, we'll just consider, are we winning? No. If that is not the case, then why are we going to stop the medication and leave the affected individual to be suffering? No. We discontinue gradually. And the reason why I've decided to put this here is that the affected individual should know that it's not going to be sudden. No cold turkey here. No cold turkey. No. Discontinue gradually. The side effects are so many. I will go over the major ones. Nausea with or without vomiting is a possibility. There may be twitching and, in fact, anticholinergic effects like dry mouth, constipation, urinary retention, blood vision. Sometimes some people will be having dizziness or fainting. Some can have seizures. There may be decreased libido. Others will be sweating profusely, and some will have trouble sleeping, while others will have drowsiness and excessive tiredness. Some will have hallucination, while a few people may develop allergic reaction or even difficulty breathing. Some will have eye pain, and some will be having fainting attack, twitching, or priapism in some men. So it depends on individual and the way individual will react, and some other medications used at the same time. In fact, I cannot go through the list of all possible drug-drug reaction right here. Please contact your pharmacist. Now, warning. In children and adolescents, we might be faced with danger of suicidal thoughts or even suicide. I had the opportunity of interacting with someone in the past when a young girl of 13 was placed on antidepressant, and I did not see the emphasis on, keeping an eye on this young lady. So I became curious and then, presented my concerns because we will not, because of this concern, the danger of suicidal thoughts or suicide, we will not use it in anyone less than 12 years. So if we choose to use it in anyone greater than 12 years up to adolescency, even young adults, we have to keep an eye on them. Please, in a bid to help, we should not tilt this age group into suicide. In hepatic or renal failure, we should significantly reduce the dose, but to avoid any confusion, please contact your pharmacist. There is likelihood of worsening or aggravating bleeding, dyscrasia, or even in anyone that is on thrombolytic agent, antiplatelet or anticoagulant that could be bleeding, because that would be one of the side effects of these medications, right? If such an individual is at the same time taking escitalopram, then we are increasing the probability, the chances, the possibility of bleeding in them. In other words, anyone on escitalopram with bleeding dyscrasia, hepatic failure, renal failure, and on all these agents, then we should keep an eye on them because they may be bleeding. Still, part of the warnings will include in case of unipolar major depressive disorder. If we are giving only escitalopram and we are not adding any mood stabilizer, then we can, one day come around to have a look at the patient, and the patient will already be in the phase of mania, or if it hasn't gotten too bad, could be in the phase of hypomania. But in bipolar, where the individual have the chance of having mania before, then we will be in trouble, because without concomitant use of any mood stabilizer, we stand the risk of worsening the manic phase of the individual in bipolar. So it is practically impossible for us to use escitalopram alone in anyone with bipolar. And even if we use it in anyone with major depressive disorder, unipolar, then we must watch out. Mania could be at the door, or even lesser one, hypomania. Yes, let's go through some few facts here, and then we'll end this short presentation. I have mentioned the probability of mania and worsening mania in anyone with major depressive disorder or anyone with bipolar, but we are not using mood stabilizer concomitantly with escitalopram. Of course, that is going to be a bad practice anyway. Nobody would do that. I mean, nobody will see a patient with bipolar, with mania and depression, and use only escitalopram. I don't think so. However, if that is the case and escitalopram is being administered, let's look at some factors that could precipitate or worsen mania. Female, female gender. If we give a woman with major depressive disorder or bipolar only escitalopram without any mood stabilizer, then we might be tilting her into the manic phase the more. If there's resistance to antidepressant or these individuals develop depression early in life or there is associated psychosis, then we can be sure that we will run into this. Or there's positive family history of this. Or there's what is known as idiosyncrasy in medicine, in which case escitalopram here has been used by many people, but this individual is just reacting in this way and it's peculiar to him or her. That's another factor that will precipitate or worsen mania if escitalopram is used alone. With this, I come to the end of this short presentation. Please contact your pharmacist, contact your psychiatrist, contact your family physician. Thanks for listening. Please remember to subscribe to my channel. I appreciate it.